Today we are going to talk about a very, very important and an interesting topic of diabetes. Now, normally when we talk about diabetes in children, we always talk about type 1 as the primary focus. But today what we're going to do is that we'll discuss about 6 cases who presented like type 1 diabetes, were managed with insulin at one point or the other. But ultimately they had something interesting in them, as to some of them might we are able to switch over to a particular oral medication. In some cases we were able to look at more complications, other issues. So this is the importance of how we go beyond type 1 diabetes, and this is what we're going to discuss about today. We've got 6 interesting cases which will be covered sequentially, covering the entire range of non-type 1 pediatric and adolescent picture in that regard. So this was a 16-year-old girl with polyuria. Blood sugar was 440. HbA1c was on the higher side and was ketotic. So this is a classical case of a ketotic diabetes, and labeled as, of course, type 1 diabetes, managed with DK and insulin. Over a period of time, we were able to reduce the doses significantly. Now, this child happened to be on the overweight, obese side. There was a strong family history. So the treating physician thought that this is more likely to be a type 2 diabetes rather than type 1 diabetes. And at that point of time, metformin and insulin were both stopped. But unfortunately, the child presented later on with DKA. So this is a big diagnostic challenge. We have got a child who presented with onset with diabetes in DKA, but because of other aspects, low insulin requirements, insulin was stopped and then again went into DKA. So this is something which was which we needed to work out, and what we found was this child was GAD positive. So if we look at this picture, there is often a confusion between whether what is type 1, type 2, LADA, and all those aspects, and this becomes important, which we will discuss subsequently. Another child, 18-year-old girl with increased urine output, blood sugar slightly high, HbA1c not that high as compared to the previous report, ketone levels slightly elevated. So again, mild or hypoketotic, lean individual without acanthosis. So we are not thinking about type 2 here. What we are basically looking at, this was diagnosed as type 1 diabetes, but with minuscule doses of insulin was having recurrent hypoglycemia. So again, first case was type 1, which was not thought of type 1. This is not really type 1, but it was thought of as type 1. So there is often a confusion as to considering something as diabetes type 1, not considering when it is required. And this is the whole confusion about. So this, if we had gone through our algorithm, somebody who did not present with DKA, who did not have obesity, we should have had measured the GAD antibodies. And in this case, the GAD antibodies were negative, and that would have led to the evaluation for genetic causes. So what we're trying to do based upon these 2 cases is to emphasize that there needs to be a careful evaluation and an organized approach to reach a particular diagnosis. Now, earlier it was very easy when we talked about diabetes that this is type 1 diabetes. There is a lean individual with ketosis who has insulin requirement, and that's the end of the story. On the other end of the spectrum, we had type 2 diabetes, who is an obese individual, insulin resistance, is able to manage with OHA. But now we know that there is a big spectrum, right from insulin deficiency to insulin resistance. And this is what is difficult and confusing. We have got in between, we have got neonatal diabetes, which is a unique form of diabetes, which we'll emphasize. We've got monogenic forms of diabetes, latent autoimmune diabetes, and of course, ketosis-prone diabetes. So there is a whole feature in which type 1 behaves like type 2 and type 2 behaves like type 1, and there are things in between. And this is what we want to discuss about with regards to the various cases which we'll highlight in that regards. So this is the basic topic, how and when to suspect and evaluate and manage that. So we'll initially have a brief overview, and then we'll go into the cases. You can all go and have a look at our website, learning.growsociety.in, for more resources and information. We have got many courses, including the master course, Pediatric Endocrinology for Fellows course, for postgraduate course, the books, and the app. And we'll use the app as a way to how evaluate. This becomes very easy if we do it in a logical manner in that regards. Now, when we talk about diabetes, we are basically talking about insulin production and insulin action. Now, where does the insulin come from? Of course, insulin comes from the pancreas. And the pancreatic development is such that there are 2 different components of pancreas, the exocrine and endocrine. Just like thyroid has got the follicular and a parafollicular. Adrenal has got cortex and medulla. Pituitary has got adenohypophysis and neurohypophysis. Remember, these are glandular component and neural component. So you can think of pancreas as having a glandular component, which is the exocrine part, as well as the beta cells, which are essentially neuroendocrine cells. So in a way, these all endocrine glands have got both neural as well as glandular component, and pancreas is a typical example. You've got two different buds which come and then fuse together and then rotate. Now there we have got various regions which produce the enzymes. So these are the exocrine parts, but what we are focusing are more in terms of the endocrine parts, and there are three major hormones coming out of here: insulin, glucagon, and somatostatin. Insulin and glucagon are basically there to control the blood sugars, while somatostatin will inhibit both the secretion of insulin and glucagon. So if you have an isolated effect with regards to the beta cell function, you will predominantly have only insulin secretion issues and you will have diabetes. If you have a insulin and glucagon effect, what will happen, Sayan, in that case?
So in those cases, increased chances of hypoglycemia will be present.
So you will have nothing to rebound in that sense. So you will have hypoglycemia, which will happen. And of course, if you have got the entire pancreas gone, you will also have steatorrhea, which will happen. So this tells you at which stage the problem is in that situation. Now, there are a number of genes which are involved in pancreatic development. PDX1 is very important when we talk about neonatal diabetes, because this is involved in pancreatic development in that perspective. Now, once the beta cell is formed, it has to produce the insulin. And insulin production is a complicated process. It takes time. So do you think insulin production is the major site of its regulation, Manoj?
Yes.
Is it the production or the release?
It is a release.
Release. So you have to keep your store ready, because if your sugar is going up and then you start producing insulin, it is going to take a long time. So body stores insulin already, but you need to understand production, because if you don't have a production, of course, what will you release? So this is important for more chronic sort of disorders in which you can have. And this, of course, involves the insulin gene, which produces a large pre-proinsulin, which we'll discuss subsequently, which is regulated by a number of transcription factors, which act in concert with each other. Now, these transcription factors have a promoter. So basically, you know that when you have a gene, there is a promoter and an enhancer, and along with that, the transcription factors will then attach to that particular promoter or enhancer to cause the increased gene synthesis. The major ones include HNF1 alpha, PDX1. Now, PDX1 is developing pancreas, but also regulating insulin release. Something like, which other gene can you think of in endocrinology, Naveen, which is responsible for both development of a gland as well as production of a hormone? We talk about PDX1 is developing pancreas and also regulating insulin release. There is one more very interesting gene which regulates the development of the gland, two glands actually, and production of hormones.
That one is actually for genital and adrenal development.
And
For the
steroidogenesis, very good. DAX, and I was thinking of NR5A1 because that is a more important in terms of development. So these are the genes which not only develop the structure but also the function. So PDX1 is that group of a home box gene which is there. Now there are other ones like NeuroD1, HNF4 alpha, and HNF1 beta and HNF4. So they all interact with each other to produce insulin. So of course, if you have a defect in any of this, which we'll discuss subsequently in two of our cases, you will have a problem in terms of development of diabetes, which is known as monogenic forms of diabetes. Now, insulin is synthesized as a large molecule, just like pre-pro-PTH, pre-pro-insulin, and pre-pro-AVP. You've got this large molecule which is there, which is then cleaved into pro-insulin. And from there, you have got pro-convertase, which converts it into insulin, and Cpeptide. Now, this has got two implications. If there is a problem of the enzyme pro-convertase, what will happen in terms of overall body system, Pratik?
So there will be hyperglycemia, diabetes.
Yeah.
And also, sir, ACTH deficiency.
There will be a ACTH deficiency. What else? So pro-opiomelanocortin. So your ACTH will go, your MSH will go. So there will be depigmented here, and MSH other action is MC2. MC4 receptor, appetite. So if you have an obese child who has depigmented hair, ACTH deficiency, diabetes, and possibly diabetes insipidus, you're dealing with a pro-convertase defect. So just understanding this physiology helps you a lot in terms of reaching a particular diagnosis. The second, of course, is that C-peptide has got nothing to do with glucose metabolism. It is a byproduct of insulin production, but it is stable. It has got a longer half-life and therefore is the best marker of insulin status, which we'll use later on in our cases, how to differentiate between insulin deficiency versus resistance in that perspective. Now, this is the most important aspect. As we were discussing, insulin is mainly regulated at the level of release. The body wants to release insulin when you've got enough energy. So if your ATP level in the body is high because your glucose is more, which is entering the beta cell via the GLUT2 pathway. You have got the GCK, glucokinase, which is causing conversion to glucose 6-phosphate, and it is then causing ATP production. You will then release insulin. Now, what is the big difference between GLUT2 and other transporters, Sayan? So GLUT2 is in a way a sensor of glucose in the body. So amount of glucose you have in the body, it enters into the beta cell. All the other GLUTs are usually insulin dependent. Now, do you want GLUT to be insulin dependent?
No.
If it is insulin dependent, what will happen? Your GLUT will become more, glucose will come in, more insulin. So this will be like a vicious cycle. You will continuously have hypoglycemia. So GLUT2 is unique that it is non-insulin dependent. So it just passively allows glucose inside. What about GCK? What is the difference between glucokinase and hexokinase? Which is the major enzyme in the body for the energy production? So what's the difference between GCK and hexokinase?
It only converts glucose to glucose 6-phosphate. Also something to do with Kmax.
Yes. So it will work at a lower level or at a higher level. So it is unique for the beta cell that it's just measuring how much you have. It has nothing to do with energy production. That's hexokinase works is there. This fellow is just there sensing glucose. And this is very important and relevant from the case Pratik will talk about, that if you have increased glucokinase activity, body will say, okay, we've got huge amount of glucose, let's produce more insulin. Or what will it do? What will happen then?
So glucose sensing will be increased, so insulin production will be there.
And you will have hypoglycemia. If you have the other way around, if your GLUT2 is less and if your GCK is basically on the lower side, body will say, okay, we don't have any glucose in the body. Let's basically be cautious, don't produce any insulin. And that will cause, so one will cause neonatal hypoglycemia, the other one will cause the hyperglycemia or diabetes. Now, this is an interesting dose phenomena. So when you talk about MODY, what is their mode of inheritance usually? Dominant, recessive, X-linked? Dominant. So if you have a single GCK defect, you will have this mildish diabetes and you will not sense it, but once the level goes up, you start sensing. But if both the genes are gone, you will have the most severe neonatal diabetes. So this is just a simple dose effect which happens. So normally what happens is that this is a potassium channel which is surrounded via the two subunits, the ABCC8 and the KIR. So one is responsive to sulfonylurea. And in this setting, what will happen is that if your potassium is continuously open, there will be no depolarization. So your all potassium will be leaked out and the calcium cannot enter the cell, the insulin cannot go out. So this is the normal mechanism. Now what happens is that if you give sulfonylurea, basically they will cause this potassium to go inside, and after that you will have depolarization, the calcium will enter and the insulin will be released. So basically the problem here is of two folds. One, you're not sensing the glucose via GLUT2 or GCK, and second is your potassium channel. So your potassium channel is open. So continuously you are leaking potassium, not allowing depolarization, and that's why you will have diabetes. You give sulfonylurea, they will improve. So this is the most common form of neonatal diabetes, and a couple of forms of MODY as well, which we'll discuss later upon, the potassium channel defect. So if you understand the basic physiology, it will become much easier in that regards. Now, how does insulin act? What is the type of insulin receptor? Which type receptor it is? So it is an intrinsic tyrosine kinase receptor. So what it does, it has got two alpha unit like this, and along with that there will be beta units which are there, and within the beta units you will have the tyrosine kinase which is there. Now once the ligand binds to it, the alpha units will come together, and once they come together the internal units will also come closer, and once you do that you will basically have the approximation of the tyrosine kinase on both chains, and the action will start. So this is how the tyrosine kinase, so this is an intrinsic tyrosine kinase, and it is interesting, most other recruit kinase. So if you give, can you give an example of which hormone uses a receptor which gets kinase from outside? Most of them. So, but if you remember growth hormone, JAK-STAT pathway. So it gets Janus kinase from outside. If you talk about cyclic AMP, again it will activate through that pathway. The G protein couple will cause cyclic AMP, then protein kinase A. But here within the receptor they have given, so they want immediate action. So this will be one of the fastest receptor that you will see. You don't even need to get a kinase out of it. It will immediately start acting. Now, once that happens, you will phosphorylate and you will produce multiple substances, IRS1 and 2, PI3 pathway, which will allow glucose uptake, particularly through the GLUT4. Along with that, you will have other things which will cause cellular growth. So we don't go into all that. But what you need to remember is that then, so we talked about pancreatic agenesis, we talked about beta cell problems, we talked about the problems in the various transcription factors, we talked about insulin production, insulin release, and now insulin action. So these will be the various causes of diabetes that will be there in that perspective. So if you now talk about pathophysiology, we all know that insulin has to come out, so insulin release and action. So it's a very, very simple process. You have to have a balance between secretion and action. So either your secretion is less or your action is less, or both are low but not that low, but combined they will have a problem. So in a nutshell, diabetes is a disease of relative insulin deficiency. So it's relative to your insulin action. And in this setting, the best marker is the disposition index. What is disposition index, Naveen?
So basically it is the balance between the secretion and action, sir.
So what is it in absolute terms? So how much glucose you can dispose. So this is basically giving you an idea. Okay, if you get 8 milligram per kg per minute, I'm able to dispose, but if I get 12, I won't. So this is the disposition index. If your secretion is less or your action is less, your disposition index will come down. Now, based upon that, if your secretion is reduced and your action is increased, you will still not develop diabetes because one can compensate the other. So this is like pre-type 1 diabetes. If your secretion is reduced, but your action is normal, so you're not hypersensitive, you will then enter into type 1 diabetes. And of course, similarly, you can have a problem in terms of increased secretion compensating for type 2. And then finally, you will have both low and you will cause diabetes. So it's a relative term. Don't just go that everybody will have a low synthesis or a resistance. It's a combination of the two. Now, diabetes, based upon whatever we have discussed till now, could be because, of course, because of deficiency or resistance. Deficiency could be genetic, which we'll talk about later. It can be acquired, most common is type 1, of course, and pancreatitis, which Sayan will talk about in a case. Then we have a genetic problems of resistance, which will be the insulin receptor problems largely, and acquired problems like obesity, type 2 diabetes, and drugs, which becomes important there. So type 1 diabetes we won't be discussing is a combination of genetic predisposition with environmental trigger producing immunity, which is causing damage to the beta cell. So this is typical of immune diabetes, and we all talk about and know about that in detail. The only thing to remember is that the major cause of type 1 diabetes is which form of immunity?
So T cell.
Cell-mediated immunity, but we do not measure T cell because it's not easy. What we measure is the secondary phenomena, the GAD antibodies, the ZNPT antibodies, which are the epiphenomena, but not the cause of diabetes. So if somebody says, okay, my GAD is so high, it is not going to do any problem. It's just a marker of the disease. It's not the cause of disease in that perspective. Now, type 2 diabetes is basically an issue about how you handle your fat. If you have got fat which is reasonable, the body will store in your subcutaneous tissue. If the fat becomes too much, it will then spill over and get deposited in the muscle, in the liver, and other regions, including the pancreas as well. And this is when you develop insulin resistance, and that causes a type 2 diabetes. So type 2 diabetes is essentially an imbalance between your storage capacity for the fat and how much fat you have. So of course, if somebody is SGA and they've got lesser capacity, if they gain weight, they will have a much higher tendency of developing diabetes in that perspective. And usually, and I would say usually because I have not seen hardly 1 or 2 cases maybe who are pre-pubertal, but it's always pubertal. Obesity is a plus minus. If you are SGA, it may happen with lesser weight, and maybe body fat is a better indicator in that setting. But yes, pre-pubertal, it is very, very unlikely in that setting. Why do you think puberty is causing these problems, Pratik?
Fat increases there.
Yes.
And LH is causing the increase.
So testosterone, growth hormone, so all of these cause insulin resistance. Puberty is an insulin resistant state. That's why you become permanent. Now, the most severe form of diabetes that you will ever see is this, lipodystrophy. Now, what happens in lipodystrophy is just the opposite of obesity. You don't have any fat. So why do you have insulin resistance in this setting?
Because there is no adipocyte to store the fat. So fat will store mainly in the visceral organ, like
yes.
Liver and pancreas. That's what the insulin resistance.
So exactly. So when you compare obesity and lipodystrophy, clinically you will say they don't have any fat, so why should they have diabetes? But they are the worst form because they don't have any capacity to store diabetes. And what happens is that all the fat goes directly to the tissue. They can't store zero. So any amount of fat will cause all these complications, adipocytes and diabetes. So this is the most difficult situation to handle. This causes severe diabetes with fatty liver, with dyslipidemia, huge insulin requirements up to 3 to 5. And the only treatment what you can give to them is? Naveen? You can build their fat. So leptin. So leptin is what is produced, because leptin is an important factor. If you don't have any leptin, that will also cause a problem. So you will give leptin. That is the treatment which can be the option in this setting. It can be congenital and acquired, and we'll discuss about this later. So this is the most severe form, I would say, of type 2 diabetes in that setting of lipodystrophy. Very high insulin requirement, absolutely lean, looking muscular. They will have veins very prominent, so they will look like otherwise lean, but they will have muscles, and that's very important. We'll discuss about that in the case which Naveen will talk about in that perspective. Now, MODI is not a term we should use now, because now people talk about individual diagnosis rather than saying MODI, because there's nothing which is similar between them. They are entirely different disorders. You can have a problem in the HNF1 alpha, which is basically one of the most common ones. It is progressive, but they respond very well to sulfonylurea in that situation, and they tend to have early glucoseuria. So you can detect them from that perspective. HNF4 alpha again is a progressive one. HNF1 beta, which we'll discuss today, is a problem which also associated with renal problems and hyperuricemia. Glucokinase is an interesting situation. It is not a problem of insulin synthesis. It's a problem of sensing. It's like calcium sensing receptor defect. So if you have inactivating calcium sensing receptor defect, you have hypercalcemia and hypocalciuria. If you have an inactivating GCK defect, you will have hyperglycemia. If you have an activating, you will have hypoglycemia in that regards. But then this is more like shift of the curve. So your insulin to glucose response curve is shifted to the right side. So what will happen is that you may not produce insulin at a fasting sugar of 110, maybe you will produce at 120, but once it goes to 150, it will be produced and it will take care of it. So the hallmark of GCK defect, as Pratik will talk about, is that the difference between the fasting and the post-meal value is very, very narrow. And that's what will give you the diagnosis and clue in that regard. So whatever we're discussing all has clinical relevance and easy to identify in that regards. And then there are other forms of MODY. PDX1, as I discussed, is a pancreatic agenesis, and then NeuroD1, which is a progressive disorder. Coming on to a very important aspect, which Manoj will talk about, neonatal diabetes. Again, many of them are transient. So don't rush if you have a neonatal diabetes. If it's a very early onset, sick child with the DKA and with ear creases, with features of omphalocele, features of Prader-Willi, it is most likely an imprinted form of diabetes which will be transient. So transient diabetes is half and half as permanent, and this is, as discussed, most likely 6q24, which is associated with all those Beckwith-Wiedemann-like features, omphalocele, ear creases, which become relevant, and then of course potassium ATP, milder defects can be transient. Now all of these transient also develop later on in life type 2 diabetes. So always we remember that they will have mild course here and then they will develop later. Why do you think this is happening, Manoj? Why do you think they have diabetes later on, they had now and then later on? Basically, they have got lesser reserve. So when the body needs more, maybe in the neonatal period or around puberty or around that time when the resistance becomes more, they become evident. If you have a more severe defect, it will last for a long time. If you have a milder defect, it will present early and then go off and then come back again. So you have to be very careful in terms of long-term follow-up of that. And then permanent maybe beta cell or syndromic association in that regards. So we discussed a lot of theory. Now the practical issue. You get a case and you say this is type 1. When should I start thinking of some other form of diabetes? Simple as that. If the onset is before 1 year, before 6 months, definitely neonatal. 6 months to 12 months, get a GAD. If it is negative, then you think of neonatal. If the requirement is less than 0.2, 0.3 unit per kg per day, beyond the honeymoon phase. Now, what is a honeymoon phase? And this is a big confusion in the first case, which Naveen will talk about. Typically, after 15, 18 months, definitely. After 12 months, again, you have to be a bit concerned about that. So that will indicate it could be MODY. If antibody negative, still could be MODY. And if there is a strong family history, again MODY. Now remember, lot of type 1 patients are getting obese because obesity is becoming so common. So just because somebody is obese does not make that child type 2. This is important to understand from that. Of course, people say that type 1 and type 2 are the same. There is an accelerator hypothesis which says that because of obesity, the overall development of type 1 is accelerating. So it is not that there's two different diseases, it's the spectrum of different diseases. But clinically, if you have obese type 1, most likely, like the first case which saw, unless you do a GAD antibody and that is negative and he does not need insulin, then only you stop insulin. Otherwise, be careful in that setting. What about type 2? You think that this looks like type 2, but there is no acanthosis or obesity. So if you have a pubertal individual who is non-ketotic, you say, okay, this is not type 1, this could be type 2. But remember, this could be MODY or LADA as well. Also think that if you are giving somebody sulfonylurea and within a year he is not responding, this could be LADA most likely, and you should actually avoid sulfonylurea in that setting. If you have to give an oral medication, you should give metformin and DPP-4 inhibitors, which are better in that situation. If of course you have a ketosis, this could still be LADA. And if there is an abnormal fat distribution, think of lipodystrophy as a possibility in that regards. Now, how do you classify? So if you have a pubertal onset with strong family history, with severe obesity, 90% cases, mild disease, non-ketotic, usually you're talking about type 2. Any age onset, variable obesity pattern, more severe ketotic, start thinking of type 1. Strong family history, 3 generations involved, along with pubertal onset, and you have got population prevalence of obesity, think of MODY, which becomes important. Now the key question is, which of these has the highest predictive value in regards to differentiating between type 1, type 2 and MODY? Pratik, out of these clinical parameters. So I would say if there is ketosis and persistent insulin requirement, you don't need to worry. If a child had DKA and still requires insulin, don't worry about classification. This is basically a classic case of type 1. On the other hand, obesity with no ketosis, this is most likely type 2. Lean with no ketosis, MODY. But then all of them have got different pre and post test probabilities. So what you do there are two tests which will help you classify further. But again, nothing is absolute. One is to look at the immune status, which is autoimmunity. And the second, HLA is not very good, Cpeptide. So these are the two parameters which are going to help, and we'll show in all cases how they helped us reach a diagnosis in that perspective. So clinically, you can look at BMI, which is a plus minus parameter, as I said. Family history, now so many people have diabetes, so you can easily get a 3 generations. So it doesn't mean that if the grandfather had, father had, you should do a MODY testing. No, you have to think of other things as well. But yes, if you have a lean individual, non-ketotic 3 generation, start thinking of a possibility of MODY in that setting. Always ask for drugs which can cause like steroids, pentamidine, all those drugs in that regards. Look for clinical features of insulin resistance, fat distribution pattern, liver size, clinical parameters, skeletal abnormality that one of our cases will tell you, will be able to identify that. Now, the key question for a clinician is, I want to distinguish, okay, this is type 1 and type 2. How do I do that? Now, my answer to that is that don't be obsessed with the type of diabetes. Your initial aim is to treat and correct the hyperglycemia. So if somebody is having a very high sugar, who has osmotic symptoms, don't bother too much type 1, type 2, start insulin. Only if somebody is mildly symptomatic, then you start thinking, okay, whether we give metformin or other fat factors. But it's very important first to correct the symptoms. Now, if you want to go for diagnosis, there are two things you can look at: autoimmunity and beta cell reserve. Now, Sayan, which will be better in the beginning and which will be better in a follow-up situation? So you have a child who has come to you now, you want to say it is type 1, type 2, which one will you do? If you want to say 2 years later, which test will help you better, which has got a higher discriminatory value?
So initially autoimmunity is better. On follow-up, sir, when we have confusion regarding type 1 MODY, we can go in for beta cell reserve.
So what's the role of autoimmunity in terms of type 1 diabetes? What is its major role? Is it ruling in or ruling out?
So it's ruling out other causes and also ruling in.
So if it's ruling in basically, so ruling out other causes, ruling in diabetes. Na? So if your GAD is strongly positive, you can say, okay, this is most likely type 1. If it is negative, it can still be type 1. So its major role is ruling in. What is the role of C-peptide or a beta cell reserve?
C-peptide is whether the reserve, the beta cells are functioning.
No. Is it ruling in or ruling out?
It's ruling out.
So if your C-peptide is pretty high, it rules out type 1. If C-peptide is low, it can still be low because of glucotoxicity. So what you need to understand is why you are doing those tests. GAD is to rule in diabetes. C-peptide is to rule out diabetes. This is the primary role which you need to understand in that perspective. So this is more like a prediction. So if you GAD in the beginning, because as time goes by, the antibody prevalence will come down in that regards. And beta cell reserve is more like a later part. So maybe 2 years later, still you have beta cells left. It is not type 1. It should have been 0 by that time. This is what becomes relevant. So it is early in disease, you can do GAD, IA2, ZNPT. I would say GAD is good enough in most cases. And late in disease, you can look at beta cells reserve. And of course, genetics, not much role of HLA. Now, when you talk about beta cell function, you can either measure insulin, which has got 2 phases of response, which has got a short half-life, is a labile hormone, versus C-peptide, which has got a long duration of action, long half-life, stable. Which one will you choose, Manoj? So anybody will say that, okay, C-peptide is much better. So insulin has got no role in routine diagnosis and evaluation. It has a role in terms of research if you want to do those euglycemic, hyperinsulinemic clamps and all, but don't measure insulin because it is not going to tell you what is happening in the portal system. It is just a peripheral insulin. If you keep the insulin tube, it will go in 5-10 minutes, your levels may change. So don't go for insulin, go for C-peptide if you're really concerned in that regards. That becomes important. So if you compare Cpeptide has a long half-life. It gives you information about portal status. It is stable and it is more of a clinical role, while insulin is more for research purposes. Now, what cutoff? Now, the debate is whether you should do a stimulated Cpeptide after eating something or you do a fasting Cpeptide. There are cutoffs which are there. But what you need to remember is that if there is hyperglycemia, if your sugar is more than 180, it is already stimulated. Your Cpeptide should be high. So these, and they are figured in nanomoles and nanograms, which you can convert easily. So if your level is very low, then type 1 becomes likely. As the levels go up, so again, don't go for one cutoff, that this cutoff is there, it is type 1, this is type 2. No. If your level goes above 1, it is very, very unlikely that this will be type 1. It can still be, but very unlikely. While if it is less than 0.2, it may be glucotoxicity. So this role is mainly for ruling out diabetes, not ruling in type 1 diabetes in that perspective. So just the final aspect, how do you classify diabetes? Onset less than 6 months, you think of neonatal, do imaging and then genetic studies. If the imaging is not clear, you want to know whether pancreas is formed or not, what is the better test, Naveen, in this setting? Which test will give you pancreatic information?
So we can do a stool elastase, or we can do
CT. So fecal elastase is the best marker, because even on CT sometimes pancreas is not very clearly visible. Now, if the onset is after 6 months of age, whether there is a decayed presentation, yes, and the child is needing insulin, this is type 1. Don't worry. So decay at onset, insulin requirement, don't do any workup. If you do not need insulin now, it may be honeymoon phase for some time, but maybe 1 year, 2 years, still not requirement, then you do a GAD antibody. If the antibody is positive, this is type 1. If it is negative, go for MODI. On the other hand, if there is no decay and there is no obesity, now this is a confusing picture. This can be MODI or it can be LADA, because it may evolve over time. So don't leave it, do a GAD antibody. If the antibody is positive, this is LADA. If it is negative, go for a genetic study in that perspective. And if there is obesity, no ketosis, child is stable, this is most likely a type 2 diabetes. So this is how you classify. So don't do investigations in everybody. You just classify like that. We'll take the case again. The first case, 16-year-old polyuria. What we found here was that he actually presented with DKA. But the problem was that because he was obese, we thought that this could be non-type 1 diabetes and stopped. And the problem happened that he presented with DKA later on. So if we just go by our algorithm that we have discussed, we say that this child has hyperglycemia, age is 1 to 18. He presented with DKA. He does not require insulin. You should have got a GAD antibody done. And that could have prevented you from developing this DKA. Second case, the same 18-year-old girl with increased urine output. And in this case was labeled as type 1 diabetes, even though there was no DKA, and was a lean individual. GAD was negative and turned out to be a MODI sort of a form. So if you look here, again, you have to look at in somebody who doesn't have a DKA and who is non-obese, the key parameter there is to look at GAD antibody. If it is negative, go for a MODI testing, which becomes important in that setting. 16-year-old boy with obesity, there is hyperglycemia. HbA1c is 8.3, ketone is 0.8, BMI 32, acanthosis present. What do you think here, Sain?
It's most likely type 2, sir, because acanthosis and all are present.
So this is already obesity without DKA. So again, more than 1 year, obese, no DKA. This is most likely type 2 diabetes in that setting. Now, because the HbA1c is not very high, you can start on metformin alone in this setting. And finally, you've got this 18-year-old girl with obesity, similar picture, but HbA1c is 10, mild ketosis. So what will you do here?
Sir, is the patient having hospital symptoms?
Ketones are present.
Sir, will require insulin initially.
So better to start insulin, maybe basal insulin rather than a proper basal bolus for type 1. So this is how the algorithm will tell you. 1 to 18 years, DKA is not there per se, but there is ketosis. Child is obese. You have to consider that maybe basal insulin will be required in this setting. So this is where you can classify. So essentially what you're looking at is 3 things. The age, 1 year, 1 to 18 years. Second is with regards to decay, yes, no. Obesity, yes, no. Just 3 things, and most of the things come out from there. And then you have to do 2 things, GAD antibody and genetic study. That's it. So this is how we have put our algorithm from there.